Hello, everyone. Welcome to NDARC's weekly webinar. I'm Alice Havard, a Senior Research Fellow at NDARC, and it's my pleasure to be hosting today's webinar. I would like to begin by acknowledging the Wangal people as the traditional custodians of the land from which I'm joining this meeting. And I'd also like to acknowledge owners of country throughout Australia, noting that our speakers and audience are joining from many different parts of the country. We pay our respects to elders past and present and extend that respect to any First Nations people present today. Now, it's my great pleasure to introduce today's speaker, Dr. Jaleh Golami. Jaleh joined NDARC as a postdoctoral research fellow in 2022. Prior to this, she was based at the Iranian National Center for Addiction Studies at Tehran University of Medical Sciences, where her research focused on the epidemiology of alcohol and other drug use and related harms. In this webinar, Jaleh will be presenting data from a series of systematic reviews on the epidemiology of prescription opioid use in Iran. I'm pleased to let you know that during question and answer time, we'll have the opportunity to hear from two additional experts in this field who happen to be Jaleh's co-authors on these studies. We have Afarin Rahimi, who is Professor of Psychiatry and Director of the Iranian National Center for Addiction Studies. Afarin also has experience in government roles in Iran, including Director of the Offices on Mental Health Services in the Iranian Ministry of Health. We also have Yasna Rostam Abadi, who completed her PhD under the supervision of Afarin and Jaleh and is now a postdoctoral research fellow at New York University. Jaleh and the two panelists will take questions from the audience after the presentation, and you can log questions using the Q&A function in Zoom. Please do use the Q&A function rather than the chat option. And I will attempt to relay as many of these questions to the speakers as possible at the end of the presentation. But now I will hand over to you, Jaleh.
Thank you, Alice. Thank you for your warm introduction, and thank you everybody for joining us this afternoon. Today, I'm going to talk about the epidemiology of prescription opioid use in Iran. Specifically, I will present 3 published papers on the prevalence and trends of methadone, buprenorphine, and tramadol use, along with their related health consequences. This research has been conducted by the Epidemiology Department of the Iranian National Center for Addiction Studies, affiliated to Tehran University of Medical Sciences, and I'm excited to share it with you today. I'd like to begin my presentation with a brief introduction to Iran. The country of Iran, which is also called Persia, is situated in the Middle East and Southwest Asia, and Eastern Mediterranean region according to the World Health Organization classification. The shape of Iran on a map is like a sitting cat, bordered by Afghanistan, Pakistan, the Persian Gulf, Iraq, Turkey, Armenia, Azerbaijan, the Caspian Sea, and Turkmenistan. It's the 18th largest country in the world by land area and has a population of more than 85 million. Regarding substance use, Iran has a high rate of illicit drug use, higher than the global average. 5.8% of adults in the general population, aged between 50 to 64 years, reported any illicit drug use in the past 12 months. This number is approximately 6 times higher among men compared to women, 10.2% among men and 1.5% among women. And 2.1% of adults in the general population have drug use disorders. In other words, 1.2 million population with drug use disorders. Opioids are the most prevalent drug used in Iran. The geographical location of the country and its proximity to Afghanistan, which is the world's largest producer of opium, has been one of the main reasons for the high prevalence of illicit opioid use in Iran. 3.9% of adult general population report using opioids in the last 12 months, and 1.8% of adults have opioid use disorder, which means almost 1 million population with opioid use disorder. According to the last World Drug Report, as you can see on the map, heroin is the primary opioid used in the majority of countries globally. But in Iran and a few other countries, opium is the main opioid. So to address the issue of high rate of opioid and its associated health consequences, particularly following the HIV epidemic in 2002, which has largely due to injecting drugs, Iran established a multimodal addiction treatment system. As part of the system, the country scaled up the opioid agonist treatment, specifically MMT, methadone maintenance treatment. More than 7,000 OAT centers are currently operating in Iran as part of the OAT program and serve approximately 780,000 clients receiving MMT and 20,000 clients receiving BMT. OAT has an undeniable positive impact on the health and social outcomes of patients with opioid use disorder, and MMT is widely regarded as a preferred treatment option. In Iran, like other countries, methadone is only allowed to be dispensed through licensed centers. However, a national study conducted in 2018 found that only half of the participants using methadone for OAT treatment received it through prescription from a licensed MMT clinic. The other half of the participants accessed methadone through drug dealers, the black market, or even herbal shops. So with the increased availability of methadone and buprenorphine, there was a growing concern for potential misuse and overdose. Unlike methadone and buprenorphine, tramadol is not usually prescribed for opioid use disorder. It's primarily used to manage acute and chronic pain. Tramadol was first introduced to the Iranian pharmaceutical market in 2002 as a pain-relieving medication. But many reports were published on tramadol-related seizures and deaths, and the spike in tramadol-related poisonings and deaths was alarming. In response, the Ministry of Health implemented control policies in 2007. Today, the abuse of tramadol is a public health concern in many countries, and we needed to know the size of the problem in Iran. So we aim to review the prevalence of non-prescribed use and use disorders of methadone, buprenorphine, and tramadol in different populations and subgroups, such as the general population, youth, students, and people who use drugs. Additionally, we aim to investigate the associated health consequences, specifically toxicity and mortality. The method of all studies were almost similar. We followed the PRISMA guideline, preferred reporting items for systematic reviews and meta-analysis. We searched the electronic international and national databases, including Medline, Scopus, Web of Science, and Persian Scientific Information Database, with a comprehensive search strategy. The search strategy for international databases consisted of two sets of key terms in all fields: the name of the drug, I mean methadone, buprenorphine, and tramadol, and the name of the country and major cities. No time or language limitations were applied. We tracked backward citations and contacted authors and well-known researchers for unpublished studies and missing information, and we requested this data from the National Legal Medicine Organization. Two reviewers screened records independently based on the titles and abstracts and excluded the irrelevant studies and reviewed the full text of the remaining records. After checking the eligibility criteria, they extracted the data. The disagreements were discussed and resolved by a third reviewer. For the quality assessment of the included studies, we used the JBI, Joanna Briggs Institute Critical Appraisal Checklist for cross-sectional studies after some modifications. We excluded interventional studies and studies that didn't clearly define the target indicator for drug use. This includes studies that didn't specify whether the indicator refers to lifetime use, last 12-month use, or any other specific time frame. And we also excluded studies that the data on tramadol or methadone or buprenorphine was reported in combination with other drugs, and the drug-specific data couldn't be extracted. and also studies where the distinction between prescribed and non-prescribed use of methadone or buprenorphine was unclear. We extracted data of bibliographic characteristics, study design and characteristics, and any data on the prevalence of last 12 months and lifetime use of the drugs in different subgroups, the prevalence of dependence or use disorder in different subgroups, and any indicator of poisoning or mortality by any definition. For the meta-analysis, we used Stata and R software to estimate pooled proportions for any indicators. With at least 2 studies available, we use random effects models and Freeman-Tukey double arc sign transformation to stabilize the variance where the proportions were skewed. Before I proceed with the findings, I want to note that we have collected numerous estimates in different subgroups. To prevent drowning in a sea of numbers, I have selected the most significant estimates to present to you today. Furthermore, before moving on to the discussion, I will compare the key findings to provide you with an overview of the results. Now let's dive into the findings. In the methadone systematic review, from 640 documents, 64 studies were included, and most of them were on methadone poisoning. I'm sorry to say that my forest plots are like tiny trees in a bonsai garden. They're just too small to see clearly, but don't worry. I will present the most important numbers to avoid any eye strain or need for a microscope. Anyway, in the general population, the pooled prevalence of non-prescribed methadone use in the last 12 months was 2.7% among males and 0.1% among females. We couldn't find any study on methadone use disorder in the general population, but in a national survey, 0.1% of male general population reported daily or almost daily use of non-prescribed methadone in the last month. This indicator was not detectable among females. In a national study of people who use drugs, 19.7% reported non-prescribed use of methadone in the last 12 months. And unpublished data from a referral addiction treatment center showed that 10 to 15% of men referred to treatment for OUD in different years had methadone use disorder. In terms of adverse outcomes, the meta-analysis of poisoning estimates showed that 10.4% of adult poisoning cases and 20.7% of adult opioid poisoning cases admitted to hospitals were methadone poisoning, and 16% of acute pediatric poisoning cases admitted to hospitals were methadone poisoning. 2.7% of methadone poisoning cases resulted in deaths. As you can see in this graph, the number of MMT centers and MMT clients has been increasing until 2016 and 17, and simultaneously there has been a significant increasing trend in methadone poisoning among adults and pediatrics, orange arrows, the methadone-related deaths, red arrow, the green arrows in the graph indicating treatment seeking for methadone use disorder and the prevalence of non-prescribed methadone use in the last 12 months in the general population didn't show a statistically significant linear trend. In the buprenorphine review, we included 15 studies out of 207, most of which were on the prevalence of buprenorphine use and dependence. We couldn't conduct a meta-analysis because we didn't have enough included studies. All included studies showed that non-prescribed use of buprenorphine in the last 12 months was lower than 0.5% in the general population, university, or high school students. In a national survey, 2.5% of people who use drugs reported non-prescribed use of buprenorphine in the last 12 months. Another study on PWID, people who inject drugs, showed that the prevalence of injecting use of buprenorphine in the last 6 months was as high as 11.8%. This study was conducted in 2006. And among OUD clients who attended a treatment center, 0.5% sought treatment for buprenorphine use disorder. We found only 2 studies on buprenorphine poisoning. A study of medical records from a poisoning referral center found that 4.9% of all cases of illicit substance poisoning were attributed to buprenorphine. A similar study found 1.2 to 2.5% of acute pediatric poisoning cases were buprenorphine poisoning. As you can see from the graph, the number of BMT clients in Iran experienced a rapid surge after 2006. But there is limited information on the trend of buprenorphine use, poisoning, or mortality over time. In the tramadol review, from 458 studies, 84 were included, and most of which focused on the health consequences of tramadol use. The pooled estimate of last 12-month use of tramadol in the Iranian general population was 4.9% among males and 0.8% among females. In a national study among people who use drugs, the last 12-month use of tramadol was reported to be 12.8%. Unpublished data from a referral treatment center showed that tramadol dependence was the main complaint in 6.3% of the treatment-seeking population. A meta-analysis of the included studies showed that 13.1% of all drug poisoning patients had tramadol poisoning. More than 1/3 of tramadol poisoning patients experienced seizure, and 0.7% of all tramadol poisonings resulted in deaths. 5.7% of all drug poisoning death records were related to tramadol poisoning. Now, I'd like to invite you to take a moment to review the crucial findings of the presented papers. Among the 3 drugs that were discussed, tramadol has the highest rate of last 12-month use in the general population, while methadone has the highest rate of non-prescribed use among people who use drugs. And methadone and tramadol both have high rates of use disorder and poisonings. However, it's important to note that the statistics for tramadol are reported for all drug poisoning and use disorders, whereas those for methadone are specific to opioid poisoning cases and OUD treatment seekers. So these numbers aren't directly comparable, but it's plausible to say that both drugs have similarly high rates of use disorder and poisoning. In this table, you can see the data on some other drugs in Iran and compare them with each other and with the global estimates. As you can see, tramadol use shows high rates compared to cannabis, and both tramadol and methadone are being used more frequently than heroin. Illicit drug use in Iran is slightly higher than the global estimate provided by the World Drug Report 2021. And opioid use is more than 3 times higher than the global average. Most of the opioid used in Iran is opium, but an exact estimate of its contribution is not currently available. Another point is that opioid use is higher than cannabis use in Iran, while the global estimate for cannabis use is 3 times higher than opioid use. I've just presented the highlights of our findings, and now let's move on to a brief discussion and conclusion. As far as we know, codeine is the most common prescription opioid in Iran, but the use of other prescription opioids, especially tramadol and methadone, are also prevalent, and the rate of their negative outcomes, such as use disorder, toxicity, and mortality, is a matter of concern. Methadone has a lower rate of non-prescribed use compared to tramadol, codeine, and opium, but a higher rate than heroin. Overall methadone use in the Iranian general population and among people who use drugs is not negligible and might be on the rise. With the expansion of MMT programs in Iran, injecting drug use, HIV, and other infections among people who inject drugs, and opioid-related deaths have considerably decreased. However, fatal and non-fatal methadone poisoning cases have increased and become a public health problem in recent years. We have limited information on the motivation for the non-prescribed use of methadone, so it's difficult to say whether it's attributable to self-treatment or recreational purposes. In addition, we must also consider the issue of diversion. Diversion of methadone from MMT programs is a global challenge faced by many countries around the world and is one of the sources of non-prescribed methadone in Iran. So there is a need for comprehensive policies to address the non-prescribed use of methadone and its health consequences. Policies should include measures to control diversion and raise public awareness about methadone poisoning, both in adults and children, and other harms of non-prescribed methadone use. Compared to methadone, the non-prescribed use of buprenorphine is less common among the general population and people who use drugs, and its health risks are very limited in Iran as in many other countries. Buprenorphine injection first appeared in Iran for pain relief in the 1990s. And the first reports of buprenorphine abuse in Iran go back to 2001. In many countries, the misuse of injectable buprenorphine among people who use drugs increased in the 2000s, but has dropped since then. A similar trend was noted in Iran. Since the introduction of sublingual buprenorphine to OAT programs in 2006, there has been an expansion of buprenorphine maintenance treatments and an increase in the number of clients receiving BMT. However, the number of clients in BMT remains significantly lower than those in MMT. Our study showed that despite the expansion of BMT program in Iran in the last decade, the extent of buprenorphine abuse is significantly lower than methadone, probably because buprenorphine is a long-acting partial mu agonist with poor bioavailability after oral administration, which makes it less desirable for recreational use. And on the other hand, buprenorphine-associated poisoning and mortality in Iran are much less common than tramadol and methadone because of the limited use of buprenorphine and the ceiling effect on respiratory depression, which makes it safer than methadone and other full agonist opioids. The situation differs with tramadol. The prevalence of non-prescribed use of tramadol is almost close to the use of illicit opioids. Misuse of tramadol poisoning among adults and children is a major concern in Iran, and seizure is one of the most challenging outcomes of tramadol poisoning. Ease of access to tramadol, even after the implementation of control measures, is a problem. It appears that in the last decade, tramadol abuse and poisoning have been of concern in many countries, and regulation of tramadol market has caused considerable challenges for policymakers globally. It's important to note that as tramadol is the only available opioid analgesic in many countries and is included in the national essential medicine lists of some countries, the Expert Committee for Drug Dependence of the World Health Organization, ECDD, didn't recommend scheduling this medication. But due to the abuse potential of tramadol and its associated harms, several countries, including Iran, have put tramadol on their national lists of controlled substances. Tramadol is controlled in Schedule 3 in Iran. Despite being a controlled substance for more than 1 decade, tramadol misuse and the associated health consequences is a problem and need to be monitored and controlled. The main challenges in our reviews were the diversity of indicators with various or unclear definitions that were reported in different studies. Furthermore, the number of studies with similar indicators were not enough for further analysis and evaluation of some sources of heterogeneity. To conclude in one sentence, Misuse and health consequences of prescription opioids are public health problem, not less than illicit opioids, and need multidimensional intervention. And it's important to closely monitor the situation because the drug use pattern could be changing. Finally, I'd like to take a moment to express my gratitude and appreciation to all authors who contributed to the papers. And a special thank you to Professor Rahimi, who has been a constant source of inspiration and support, and Yasna, whose hard work and commitment have been truly exceptional. And I'd like to thank you all for taking the time to join us. I hope you found this presentation informative. If you have any questions or feedback, please feel free to type them into the QA box. Now I hand over to you, Alice.
Thank you, Jaleh. That was fantastic. Such a comprehensive overview of opioid use and harms in Iran. I'll now invite Afarin and Yasna to turn on their cameras and microphones. Welcome, Afarin, Yasna. Thank you for joining us today. I first would like to see if you would like to offer any reflections on the research that Jaleh has presented, or any comments on this research, which I know you were both involved in. Afarin, maybe you would like to go first.
Yeah, thank you very much. Thanks, Jaleh, for a very nice presentation. Actually, it was a very comprehensive presentation. In Iranian National Center for Addiction Studies, which is actually a national research center for addiction in Iran, one of the lines that we are following is to provide information through doing large-scale studies, surveys on drug use issue. And the other line is doing systematic reviews to understand and collect and gather all the information available on drug use in Iran and also East Mediterranean region. So Jaleh presented one aspect of all of these lines, which is prescription opiate use in Iran.
Yes, thank you. Yasna, I wonder if you would like to add anything.
Yeah, sure. First of all, thanks for having me. I just wanted to add and highlight the fact that these 3 studies were conducted before the COVID pandemic. So there might be different drugs being related to these 3 drugs currently after the pandemic, with regards to the treatment access for other aspects. So I just wanted to highlight this fact that these are not representative of the COVID pandemic period.
Yeah, good point. Yeah, that things have changed a lot in many jurisdictions across the world because of COVID, and I can imagine we'll see lots of changes in drug use and harms related to that. Okay, I could see a number of questions coming through. The first few are around buprenorphine. So Leila Parvaresh has asked about what the most common way of using buprenorphine in Iran is. So whether it's injection or smoking, and has commented that in Australia it's smoking because of the combination of buprenorphine and naloxone that we have here. I wonder, Jaleh, would you like to answer that, or perhaps one of your panelists?
As I am an epidemiologist, I have to talk about evidence, and I don't have any evidence to answer this question. But as I think, if I'm wrong, I'm sure that Professor Rahim Mawaqar will correct me. I think the type that are dispensed in treatment centers are those ones that are being used more frequently. And I think sublingual and oral forms of buprenorphine are most are being used more. But I don't have any evidence. This is only my opinion.
Sure.
Yes, it's correct. Yes, it's correct. Actually, almost all buprenorphine abused or misused in the country is in the form of sublingual form currently, actually. Yeah.
Yeah. Okay. And another audience member is asking if buprenorphine modified release injections are available in Iran.
No, not yet.
Okay.
We have long-acting naltrexone available in Iran, but not buprenorphine.
Yeah. Okay. And what about naloxone? Is that available?
Yes, naloxone is highly available in all emergency rooms, but we try to start a project that we have available the naloxone for those who are injecting drugs, but still it hasn't been started.
Okay. There's a related question here again from Layla about what harm reduction strategies are being used in Iran and whether naloxone might be one of those. I wonder if there are other strategies also being used.
Yes, actually, it's close to 20 years that Iran adopted a harm reduction policy because of high rate of opioid use, injecting use, and also HIV epidemic in injecting drug users. So we are using lots of evidence-based harm reduction strategies for controlling health consequences of injecting use. For example, methadone maintenance treatment, buprenorphine maintenance treatment are two of those important strategies. The other strategy is establishing drop-in centers, which are harm reduction centers providing basic foods, condoms, syringes, sterile syringes to those who are injecting. And we also provide low threshold methadone for those who are injecting and wish to use methadone as a harm reduction, not as treatment.
Yeah. Okay. Right. I think I saw a question here about access to treatment. So Jale presented some data about increasing numbers of treatment centers, but I wanted to ask, and I think one of our audience members had asked something similar around whether it is easy to get into a treatment program in Iran or if there are barriers to accessing treatment.
Yes, actually, three types of treatment are quite common and widely available. One is outpatient treatment centers, which mainly provide OAT program, but also they might provide other interventions like psychosocial interventions for those who are dependent to cannabis or to methamphetamine, which is main stimulant used in our country. And also they might provide detoxification followed by naltrexone, either oral or long-acting injectable form, and psychosocial interventions. We have more than 7,000 such centers all over the country. And the other approach which is available is midterm residential centers, which are working as abstinence-based model and only provide psychosocial interventions for detox and aftercare. There are also more than 1,000 such centers in the country. The third one is a self-help group. There are several models of self-help groups, including NA, and they are quite active. And you can see in many parks, in many areas in the country that people are gathering and they have their own groups, and people can easily access those groups.
Okay.
So yeah, so these three models are quite available, but still there are many barriers to use treatment in the country. According to our most recent national survey, which carried out only a few months ago, only 10% of those with substance use disorders have used any type of treatment in the past 12 months. So despite this number of services, you can see that service utilization is limited.
Yeah, wow.
One of the main barriers for using outpatient treatment services is the cost. Most of these services are privately owned, and so people have to pay. Insurance coverage is very low. The other important barrier is the registration system. People should provide their ID, their national ID, and they are registered for receiving methadone and buprenorphine. This is also another barrier. And the other one might be the attitude of those with opioid use disorders to use these services. Some people do not like methadone and buprenorphine. We also have opium tincture in our country as a method of treatment, which is very specific to Iran.
Yeah.
Although it has been used in India and Thailand in some periods, but it is also widely available in Iran as a method of OAT. Many those with opioid use disorders have tried several types of treatments in their lifetime and have not actually changed their habit. And the other problem or barrier might be the quality of services. Actually, we know that if we improve the quality of counseling and psychosocial services in the treatment services, we might have better results. So we are working on this aspect as well.
Oh, that's really helpful insight to understand how all those parts of the system and those barriers that you've talked about and the quality of the treatments. Do you think that might be contributing to the high rates of opioid use that you've seen in these systematic reviews, and in particular high rates of tramadol use?
Yes, actually, tramadol is something that is, many physicians out of the treatment system might prescribe tramadol for detoxification from opioids. This is one aspect. And the other one is that herbal shops are also quite active in the country, although they are not allowed to prescribe medicines. But we have this small practice that they are prescribing tramadol for detoxification from opioid use disorder, and many patients attend those herbal shops to receive. But fortunately, according to our most recent study, tramadol misuse has decreased considerably, and it is now less than 1% And this is very new information that has come out.
Right, yeah. And to pick up on a point that you made earlier, you told us that some recent surveys conducted in Iran showed really low rates of treatment use in the last 12 months.
Yeah.
Do you think those rates are representative of what's been going on for some time now, or is that perhaps related to Yasna's comment around COVID and accessing treatment after that period?
Actually, from the first days of COVID epidemic inside Iran, we released the guidelines and made some interventions to make sure that those outpatient treatment services will continue their work, and nothing will stop. And we changed some guides, some regulations for MMT and BMT, for example, more take-home doses, and allowed using virtual sessions. My understanding is that we have the same rate, the same number of centers working currently, and with the same quality. And yeah, I don't think that we are facing a shortage of such services.
Yeah.
Although we need to do another research for that, but I don't think that we will see decreases of shutdown of the services.
Excellent. Yeah. Now I saw another question about how you told us that the long-acting naltrexone is being used in Iran, and how is that being used?
It is made internally. It's not Vivitrol. It's another brand called Exopio in Iran, and it's expensive. It's very expensive, although the cost is much less than Vivitrol, which if we have to use, we have to pay in US dollars, but it's much cheaper, the Exopio that is made inside Iran, but it's still it's expensive. Not many people can use this method. And the use of long-acting naltrexone for treatment of opioid use disorder is increasing day by day. It's very new. We have started it just 1 year ago, and its use is increasing.
Okay. Good. All right. So one of our audience members would like to know more about fentanyl use, community use, and community use in Iran. Just lost the question. Sorry.
Actually, we have no evidence of fentanyl use in Iran. Even in our treatment centers, we don't have anyone attending treatment for fentanyl dependence. We have not received any information from emergency rooms or from legal medicine organization about deaths or intoxication from fentanyl. So we are not aware of any fentanyl use in Iran.
It's interesting that this audience member has noticed that it seems to be quite common in Iranian immigrants in Australia. So yeah, an interesting observation.
If there is, there are a few people that use fentanyl, there isn't any sign in the evidence.
Yeah.
Maybe in near future.
Yes, obviously it takes time and monitoring
that's right.
to produce research on these things. Yeah.
perhaps one of the reasons is wide availability of other types of opioids in Iran,
Possibly.
And one other reason,
which are much safer.
and we don't have drug checking system, and we don't check the drug, the type of drugs. So if anybody use fentanyl or they die because of fentanyl use, we are not aware of it.
Okay, right. So it might be a recording issue as well.
Yes.
Okay. What else have we got here? There's a lot of interest, many questions. So forgive me for looking away while I just pull a few out. So one of our audience members is asking about the demographics of the people that are using opioids and other drugs in Iran. Are they mostly young people, or is it spread across the population?
Colleagues, do you want me to answer? Yes, no? Jale, yes, no?
I think
Yes.
this is a very great and tricky question and needs more explanation. Yeah.
Okay, let me answer. Actually, as Jale described, there are more men using drugs in Iran. There are large difference between use of substances between men and women, even cigarette smoking. Although during past 3 decades, the rate of substance use in women has increased, but there are still large difference. The other issue is about the age of initiation of drugs. If you compare Iran to many developed countries or even developing countries, the age of initiation is higher. For example, I can say that for opioids, the average age of initiation is something like 22. And this might be one reason that's why we have limited health consequences in comparison to the wide use of opioids. When you hear about this amount of opioid use in Iran, you might think that we should have lots of health consequences, but it's somehow limited. And the main reason is that people started from higher ages than in adolescence. The demographics of people who are using opium, which is the most common drug, is quite different from other drugs like heroin. Those who are using opium are usually, they have higher ages. Most are married, most are employed and have stable lives. But those who use heroin, in them, we have higher rate of unemployment, higher rate of incarceration, illegal activities, and the pattern is quite different.
Yeah, I suppose the pattern of use of opium would be quite different because of its history as a more traditional substance.
Yes.
Yeah.
Yes.
Now,
those who are using opium are more like general population.
Yeah. Interesting. One of our audience's members has asked how many prescribers, I suppose, of oat you have in Iran.
How many prescribers of what? Which drug? Methadone?
I'd say it's oat, methadone and buprenorphine through opioid agonist treatment.
Actually, those who have license for doing that might be I can't say with high assurance, but tens of thousands.
Yeah.
But about those who are actually prescribing, it might be something around 10,000.
Wow.
And these are physicians. Currently, very few pharmacies are allowed to prescribe or to provide methadone. Methadone is provided through outpatient treatment services centers, which are licensed to do.
Okay. All right. Now we have a fairly big question here, which maybe we will end on, and that is around what do you think Australia can learn from Iran's policies on opioid agonist treatment, or vice versa? Perhaps you can learn from what Australia is doing in this space. And yeah, do you think there's something Iran can do that we see somewhere else in the world?
A very difficult question. So actually, we have learned from many countries in establishing our policy and interventions, including Australia. We have learned from Australia about centers that are providing heroin inside. And we have lots of discussions if we should start such interventions inside Iran or not. But about what Australia can learn from our experiences, I don't have anything to answer. Perhaps yes, no, and perhaps Jale, who is living in Australia for 1 year, can comment on this.
Yes, now would you like to answer the question?
Yasna, you might have some insights about what you see happening in the US as well.
I'm still learning the drug scene at the US because it's a lot different in different states as well. And regarding the Australia, I'm not sure because I don't know much about the drug scene in Australia. So
Yeah, no problem.
I want to say that I don't know much things about the health system in Australia because I'm a newcomer. But I can say that we can learn a lot from research system, addiction research system in Iran and in Australia. There are many similarities between activities that we were doing in class and now at NDARC is being done. So I think it's a good opportunity for researchers in these countries to collaborate with each other and design collaborative studies and work together on OAT or other subjects in addiction.
Nice point, Jale. And I just wanted to let you all know that there's many, many compliments and thanks for you all in the Q&A. In particular, Michael Farrell says hello and is grateful for your participation today. And there's also a hello from Dr. Nicholas Clark. So I thought I'd pass those on.
Hello to Michael and Nicholas. Nice to have you here.
Okay, well, I think we might start to wrap up now. So thank you again, Jale, Afrin, Yasna. It's been wonderful. And one of the other things that came up in the Q&A was just how it's lovely to see a panelist of women, yesterday being International Women's Day. And yeah, everyone kicking goals. And yeah, I think our audience appreciates that. So yeah, thanks again. And I know it's a funny time zone for you both. So appreciate you working outside of your normal schedule.
Thank you very much, Alice, for having us here. And thanks to Jale and Yasna.
Thank you.
Yeah, it was such an honor. Thanks.
All right. And I'd also like to thank the audience for engaging. That it was a great discussion, many really interesting questions, some of which we didn't get time to address. So as Jale offered, you are welcome to email her about any further questions. And just before we bring the webinar to the close, I'm going to just let you know about the webinars we have coming up. We'll soon have a slide on this. There we go. So next week we have Dr. Emily Deans presenting a presentation entitled "I Had Nothing and Drugs Don't Leave: Young Offenders' Perspectives on Alcohol and Other Drugs." And the following week we have Dr. Nicholas Taylor on the minimum unit price of alcohol in the Northern Territory. And the following week we have Professor Jacqueline Bowden on informing and changing Australian parental alcohol supply practices. So everyone can register for those webinars on the NDARC website. I think that's enough from me. I hope you all enjoyed the session. Look forward to having everyone join us for the webinar next week, and I hope you all have a good afternoon.